All right, vignette number 5. A 32-year-old woman presents in the ER with swollen, red, hot, tender eyelids on the left eye. She has fever and leukocytosis. When prying the eyelids open, you can ascertain that her pupil is dilated and fixed, and that she has very limited motion of that left eye. This is orbital cellulitis, another ophthalmological emergency. There are a million reasons why a patient might go to an ER with a red eye. The red eye is a very common presentation. But some red eyes are simply red eyes that are not going to make a patient blind, and some red eyes require emergency attention. And this one is orbital cellulitis. And what identifies it as orbital cellulitis? When you pry the eyelids open, you see that the pupil is dilated and fixed, and the motion of the eye is very limited. With that pus behind the eye, the little nerves that go and make the pupil work are not working anymore. The muscles that move the eye are not working anymore. This is orbital cellulitis. Patient needs a CT scan, rapid correction of a problem by draining the pus, otherwise it will destroy the optic nerve. All right, vignette number 6. It's a variant of one we saw in the trauma section. Worth repeating though. A frantic mother reaches you on the phone reporting that her 10-year-old boy accidentally splashed Drano on his face and is screaming in pain, complaining that his right eye hurts terribly. Remember, the first aid is the most important component of the treatment of chemical burns. The correct first aid is massive irrigation. The sooner the better. And so the answer for this vignette is you instruct the lady to pry the eyelids open the cold water tap, and have the boy under the running water into his eye for half an hour before the boy is brought to the ER. In the ER, there will be further irrigation done, and in the ER, more elegant things are done. We will look for the little segments or fragments of the chemical agent to remove them. In fact, you might be asked a question. A child has been in the ER because of his problem. We have irrigated his eye. A half an hour has passed since we irrigated his eye. He's ready to go home. What do you do before he goes home? We test the pH on that eye before he goes home, because he may still have another little fragment of the alkali that wasn't removed. All right, vignette number 7. A 59-year-old myopic gentleman reports seeing flashes of light at night when his eyes are closed. Further questioning reveals that he also sees floaters during the day, that they number 10 or 20, and that he also sees a cloud at the top of his visual field. This vignette should enable you to identify another ophthalmological emergency, retinal detachment. Let's review it. The retina sends one single kind of message to the brain: light and color and shape. So when something is tugging at the retina, the patient doesn't feel pain or itching or pressure. The patient sees light. So the beginning of this vignette that says the gentleman reports seeing flashes of light at night means something is tugging and pulling at the retina and stimulating the retina. Well, that tugging and pulling might be a relatively minor, incipient problem with no great catastrophic consequences yet, or it could be a significant tear, a detachment of the retina. If a significant damage has been done, if a piece of the retina has been pulled out, there will be debris and little pieces of tissue and blood and stuff that accumulates on the eye. And those are the floaters the patient sees. And how many of those floaters the patient sees indicate the severity of the damage to some extent. So if we have a patient that reports 1 or 2 floaters, he probably doesn't have as bad a problem as a patient who reports 10 or 20 floaters in the eye. And if a patient says it looks like a snowstorm, there's a lot of debris on that eye, and if the patient says there is this big cloud at the top, that actually is a lot of debris that's at the bottom of the eye. Remember, we see the world upside down. So when there is a lot of debris settled to the bottom of the eye, this is something that in fact we see as a dark cloud at the top. And so this vignette as described, flashes of light, lots of floaters, the big cloud at the top. This patient needs to be sent immediately to the ophthalmologist. He has a retinal detachment, and he needs immediate laser treatment to sort of spot weld that retina back in place and prevent it from further detachment. Well, vignette number 8 is another ophthalmological emergency, although admittedly one about which we may not be able to do an awful lot. A 77-year-old man suddenly loses sight from his right eye. He calls you on the phone 10 minutes after the onset of the problem. He reports no other neurological symptoms. If the vignette had said, the gentleman says he doesn't see out of his right eye, he cannot move an extremity, he can barely, has trouble articulating words, then the problem is in the brain. You've got a cerebrovascular accident of some type. But when the only function that suddenly disappears is the ability to see from the eye, this may be embolic occlusion of the retinal artery. An embolic occlusion of the retinal artery is an emergency. The retina will not survive much more than about a half an hour with this kind of condition. And so you would tell this gentleman, that's the answer on the exam, to be immediately, driven to the emergency room and en route to breathe in a paper bag and maybe have someone push and release his eye repeatedly. By breathing into a paper bag, you produce vasodilation, so that hopefully the little clot that is now occluding a major branch of a retinal artery may be able to go further into the tree and therefore occlude a smaller segment. And the same we hope to achieve by pushing and letting go, pushing and letting go. This lets that clot hopefully move further on and therefore do less permanent damage. Once that patient is in the ER, the ophthalmologist will do pretty drastic things. In fact, they'll probably make a hole in the eye. They will deflate the eye, so to speak, to enable, again, the differential pressure from the arterial pressure to now the deflated pressure in the eye to push that clot further, but you wouldn't do that. All right, vignette number 9. The 55-year-old man is diagnosed with type 2 diabetes mellitus. On questioning about eye symptoms, he reports that sometimes after a heavy dinner, the television becomes blurry and he has to squint to see it clearly. Actually, the last part of this vignette is not the important one. Long-standing diabetics, people who have had the disease for a number of years, eventually realize that we have a little bit of a built-in glucose meter in the eye. Because when we have a big, wide swing in blood sugar concentration, the lens either swells or shrinks, and we have different ability to focus. So many diabetics will tell you that. I eat a heavy dinner and then the TV is all blurry. I have to squint to see it. Well, that's what that means. The important part of this vignette, though, is the very beginning. Whenever we diagnose type 2 diabetes mellitus, that individual may in fact have had the diabetes for a long time. Because type 2, as you know, gives no symptoms. You sort of have to stumble upon it and find it. And so the patient may already be, the victim of damage to his retina. Part of the initial workup of a newly diagnosed type 2 diabetic is to be sent to the ophthalmologist to look at the retina. If he already has retinopathy, the ophthalmologist may be able to help, because nowadays that neovascularity that leads to all the problems can be held somewhat in check Again, the famous magic laser beam can be put to good use in cases like this. That would not be the case in the newly diagnosed type 1. The newly diagnosed type 1 is typically a child. And so when we diagnose type 1 diabetes in a 10-year-old, that child hasn't had the diabetes long enough, the 10 or 20 years that it takes for it to damage the retina. All right, we're done with the ophthalmology questions, and the next chapter has to do with otolaryngology. We're going to begin with a few vignettes where the central theme is neck masses. And so let's begin the review with a little bit of background. Neck masses could be due to either one of three general groups of conditions. Neck masses may be congenital, neck masses may be inflammatory, neck masses may be neoplastic. And our first clue, which of the three groups, comes from the mode of presentation, the timetable for presentation. The congenital neck mass obviously will usually be in a young person, congenital only. But typically, that congenital mass has been present for several years before something happened to it that prompted the need for medical attention. The inflammatory mass, on the other hand, typically has a pretty short timetable of a few days or a few weeks at the most, because beyond a few weeks, the inflammatory mass typically resolves one way or the other, goes away or drains if it was paused, so that an inflammatory mass will not be there for years and years. And finally, a neoplastic mass typically has a timetable of a few months of relentless continued growth. So with that background, let's begin to read some of these vignettes. Number one, a 15-year-old girl has a round 1 cm cystic mass in the midline of her neck at the level of the hyoid bone. When the mass is palpated at the same time that the tongue is pulled, there seems to be a connection between the two. The mass has been present for at least 10 years, but only recently bothered the patient because it got infected. First of all, the presentation is classical for a congenital mass. A young person, the mass has been there for years, but only recently there was a problem that led to seeking medical attention. And then the location, smack in the midline of the neck, at the level of the hyoid bone, somehow connected to the tongue. That makes it a thyroglossal duct cyst. We remove this with a little operation. It's called a cyst trunk operation. We remove the cyst, the middle part of the hyoid bone, and we core the muscle all the way to the base of the tongue. So we take all of the territory where little bits of thyroid tissue have been left behind. There are some practitioners who, before doing one of these operations, would insist on having a thyroid scan done to demonstrate that there is normal thyroid in the normal location. I have personally never found that to be necessary, because I've never found a patient who didn't have a normal thyroid in addition to a thyroglossal duct cyst. But some people feel that way, and I alert you to the possibility of that option being among the answers. Now, vignet number two, an 18-year-old woman has a 4 cm fluctuant round mass on the side of her neck, just beneath and in front of the sternomastoid. She reports that it has been there at least 10 years, although she thinks that it has become somewhat larger in the last year or two. The CT scan shows a mass to be cystic. Again, we know it's congenital because it's a young person. The mass has been there for many years before something was felt to be needed to do about it. In the location described, in front of the sternomastoid. It could be anywhere from in front of the tragus to down in the neck. But along that line that is in front of a sternomastoid, that is a branchial cleft cyst. And surgical removal is indicated. Sometimes the branchial cleft cyst is even easier to recognize on exam question because there is sometimes a little dimple in the skin right over where the mass is deeper inside. That dimple being a remnant of the cleft that was there at one time. And so if you have that, it's even more certain that is a branchial cleft cyst. The surgical removal can in fact be a very interesting exercise on the surgical technique, because there is one of these, one of the common ones in fact, that goes right through the triangle that is bound by the common carotid, the internal, the external, the hypoglossal nerve at the top, and the track goes right between, where we have to be very careful as we take it out. Vignette number 3, a 6-year-old child has a mushy, fluid-filled mass at the base of the neck that has been noted for several years. The mass is about 6 cm in diameter, occupies most of the supraclavicular area, and seems by physical exam to go deeper into the neck and chest. This one is a cystic hygroma. That is a classical location of a cystic hygroma in the supraclavicular area. And in fact, this physical exam that suggests it may go deeper is a good finding, because these often do go deeper into the mediastinum. And so on this one, the very first thing to do for the workup is a CT scan, because we don't want to find ourselves operating at the base of the neck through a neck incision, only to realize that the mass keeps on going deeper and deeper outside of the reach of the surgical field we're in. And so the CT scan is needed, because sometimes we need to plan these operations so that there is a thoracic approach as well as a neck approach. Let's move now to examples where we begin to look at the dilemma: is there a neck mass, inflammatory or neoplastic? Vignette number 4. A 22-year-old lady notices an enlarged lymph node in her neck. The node is in the jugular chain, measures about 1.5 cm, is not tender, and was discovered by the patient yesterday. The rest of the history and physical exam are unremarkable. With this presentation, that node was found yesterday. We would not be justified in doing any expensive, invasive investigations beyond the history and physical. Statistically, this is much more likely to be inflammatory rather than neoplastic. And so the thing we do for the node that has just been found is we give it a little time. We check this patient again in 3 or 4 weeks. If indeed it was an inflammatory node, it's probably gone 3 or 4 weeks later, or certainly much smaller than it was, or it's already pointing and ready to drain if it's full of pus. In other words, the timetable of inflammatory mass will make things obvious 3 or 4 weeks down the line. And 3 or 4 weeks in the timetable of a tumor that might be in the neck is not an outrageously extensive period of time for inactivity. So it's doable. Some physicians, because they feel compelled to do something, would put such a patient on antibiotics and check again in 3 or 4 weeks. In that case, the important part of that management is not the antibiotic, it's the fact that the patient will be rechecked in 3 or 4 weeks. Vignette number 5. A 22-year-old woman seeks help regarding an enlarged lymph node in her neck. The node is in the jugular chain, measures about 2 cm, is firm, not tender, and was discovered by the patient 6 weeks ago. There is a history of low-grade fever and night sweats for the past 3 years. Physical examination reveals enlarged lymph nodes in both axillas and in the left groin. Now this is lymphoma. First of all, we should realize from the outset this is probably a neoplastic node. It has now been present for 6 weeks and it's not gone away. So this is either a node that needs to be investigated at the very least, or perhaps a neoplastic node. Well, here's a rule for the neoplastic nodes. In a young person, multiple nodes, not only the ones that perhaps were first discovered in the neck, but also the axilla or the groin. And if on top of that you add night sweats and little fever, that's lymphoma. A node that has been in the neck for several weeks or 2 or 3 months and hasn't gone away and keeps on growing, and it's in the supraclavicular area. That is a metastatic node from a primary tumor that's below the clavicle. In other words, that is not metastasis from a head and neck cancer. That's a metastasis from lung cancer or gastric cancer or renal cancer or colon cancer or ovarian cancer. It's somewhere below the clavicle. And the third rule, the node in the neck that has been steadily growing for 2 or 3 months in an old man who smokes and drinks and has rotten teeth, that is metastatic squamous cell carcinoma. And the primary tumor is in the mucosa of the head and neck, in the mouth or the pharynx or the larynx or the tracheobronchial tree or the esophagus. It's in the aerodigestive tract in the head and neck. I might add, incidentally, that the old man who smokes and drinks and has rotten teeth, that for many years we've known is the kind of patient who gets the squamous cell carcinoma to metastasize to a node, now has company. Because we now have realized that patients with AIDS are also at very high risk to get squamous cell carcinoma. So now the lymph node in the neck with relentless growth, not supraclavicular but elsewhere in the neck, in the old patient who smokes and drinks and has rotten teeth, or in the young patient with AIDS, it's metastatic from squamous cell carcinoma. The 3 vignettes. So the one that we just read, young woman, nodes in several places, night sweats, low-grade fever, lymphoma. What do we do about that one? You can always begin the investigation of an enlarged node in the neck with an FNA. Remember that the FNA is very easy to do, virtually risk-free. And so FNA can always be the first step. There are virtually no contraindications to an FNA. An FNA, however, doesn't always give the answer. You can do it, but if there is no answer, you need to proceed further. And when we think the problem is lymphoma, as we do in this one, what we do eventually is surgical removal of the most accessible or the biggest of the lymph nodes that are enlarged, because a pathologist needs to not only confirm this is lymphoma, but establish which type of lymphoma, so the appropriate management can be done. All right, vignette number 6. A 72-year-old man has a 4 cm hard mass in the left supraclavicular area. The mass is movable, non-tender, and has been present for 3 months. The patient has had a 20-pound weight loss in the past 2 months, but is otherwise asymptomatic. You know what this means? The mass is neoplastic. It's been growing relentlessly for several months. And because it is a supraclavicular mass, we know the primary tumor is below the clavicle. Now, you may be given this very same vignette with enough hints to tell you which is the primary tumor you have to look for. It might say, and he's a chronic smoker and has been having cough and hemoptysis for the past 2 months, and then you're looking at the lung. Or it may say he's also been having blood in the urine on and off for the last month or 2, you're looking at the kidney. You know, so there may be some other indicator of which primary tumor to look for. If there is that kind of an indication, we could certainly pursue the appropriate workup for that tumor. But if you have none, like in this vignette, you can always begin with an FNA of that mass. And the next move would be, let's take it out. Because as we remove and biopsy a supraclavicular node, the pathologist may in fact be able to tell you not only this is metastatic cancer, but from where. Sometimes there is enough information there to identify the specific histological type. All right, now vignette number 7, with all the explanation we had to begin with, we should have no problem recognizing. A 69-year-old man who smokes and drinks and has rotten teeth, has a hard, fixed 4 cm mass in his neck. The mass is just medial and in front of the sternomastoid muscle at the level of the upper notch of the thyroid cartilage. It has been there for at least 6 months and it is growing. This is metastatic squamous cell carcinoma. The primary is somewhere in the mucosa of the head and neck. All right, what do we do next? Very important. Do not biopsy the node. Don't put a cut on the neck. We should look for the primary tumor first. And we do that with a procedure that is called a triple endoscopy, also called a pan-endoscopy. Patient is anesthetized, and in the operating room with proper exposure, position, etc., we look directly into the mouth and the pharynx and the larynx and the tracheobronchial tree and the esophagus, looking for the primary or primaries, because these are often multicentric. And we biopsy all of the areas that are suspicious, and we may even do the random biopsies that are done in all of the areas that could have the primary tumor. That's the correct answer. Triple endoscopy or pan-endoscopy. Don't pick the answer when you cut where the mass is and take a little piece. You might say, why? Because eventually, in the ultimate curative intervention for this patient, it may be necessary to do a pretty complicated operation that removes the primary tumor along with all the lymph nodes in the neck, a radical neck dissection, which is combined with a resection of the floor of the mouth or the part of the tongue or the larynx or whatever. And that incision that was put there to make a biopsy interferes now with the placement of the ideal incision for the operation that should be done for the patient. So it's best to have a virgin neck in which to plan the proper operation, not one that was messed by an amateur making a little cut here to get a sample of the tumor. Well, as long as we're talking about a squamous cell carcinoma that showed up with a node in the neck, let's talk about other ways that squamous cell carcinoma may show up. A 69-year-old man who smokes and drinks and has rotten teeth, has hoarseness and has persisted for 6 weeks in spite of antibiotic therapy. This individual has a squamous cell carcinoma, probably in the vocal cords. Vignette number 9, a 69-year-old man who smokes and drinks and has rotten teeth, has a painless ulcer in the floor of the mouth that has been present for 6 weeks and has not healed. That is the primary tumor. By the way, he still needs a pan-endoscopy, because remember, these often are multicentric. Incidentally, let me backtrack for a second here. What is the significance of the smoking and drinking the rotten teeth? Smoking alone is an etiological factor to develop squamous cell carcinoma of the mucosa of the head and neck. Drinking alone, alcohol alone, is also a factor. But if you put the two together, they have not just an additive but a multiplying effect. So the combination of smoking and drinking is a pretty good prescription to get squamous cell carcinoma. The rotten teeth, interestingly enough, have nothing to do with etiology. But the rotten teeth are a reflection of a certain lifestyle. The individual who smokes and drinks is not the kind of person who's always flossing his teeth and keeping them clean or beautiful. It's an individual who doesn't have good oral hygiene. And indeed, it's classical that when we examine these patients, there are just 2 or 3 rotten stumps of teeth left in that mouth, because this individual, again, has lost most of his teeth. All right, vignette number 10, we were alerted to it earlier. A 23-year-old man with AIDS has a painless ulcer in the floor of the mouth that has been present for 6 weeks, has not healed. He does not smoke or drink. That ulcer there is squamous cell carcinoma. Remember, the patient with AIDS is also at high risk. Patient number 11 is a 69-year-old man who smokes and drinks and has rotten teeth, has a unilateral earache that has not gone away in 6 weeks. Physical examination shows serous otitis media on that side, but not on the other. This again is a manifestation of a squamous cell carcinoma, this one probably occluding the eustachian tube. Again, all of these, the workup begins with a triple endoscopy or pan endoscopy. Well, let's move on now to other tumors in adults. Patient number 12. A 52-year-old man complains of hearing loss. When tested, he is found to have unilateral sensory hearing loss on one side only. He does not engage in any activities such as sport shooting that would subject that ear to noise that spares the other side. The vignette had said somebody has conductive ear loss. Well, then the most common thing would be, in fact, a plug of cerumen or something wrong with the middle ear. But if it is sensory hearing loss, you have to realize that the common explanation for sensory hearing loss pretty much all the time are bilateral. This man worked in a very noisy factory, and that's why he lost his hearing. He would have lost it from both ears. And if he was a private pilot and was flying his little airplane with a lot of decibels in the cockpit, he will lose it from both sides. And that's why there is this little extra line here that says he doesn't do sport shooting, because there is an exception where, a guy shoots, the ear that's close to the gum is the one that gets the noise more than the other. But otherwise, when we see unilateral sensory hearing loss, we immediately think of tumor. A tumor affecting the eighth nerve. So what this gentleman needs is an MRI, because the MRI is the best way to look at tumors inside the head, tumors affecting cranial nerves. So we need an MRI looking for a tumor that is affecting his eighth nerve. Patient number 13, a 56-year-old man develops slow, progressive paralysis of the facial nerve on one side. It took several weeks for the full-blown paralysis to become obvious, and it has been present now for 3 months. It affects both the forehead and the lower face. If the vignette had said a 56-year-old man went to bed looking as handsome as ever, and the next morning he woke up to find half of his face paralyzed, that would be Bell's palsy, a relatively common benign problem. But if we're told gradual loss of a function of a facial nerve on one side, that means tumor. So here again, what you want to do is an MRI looking for the tumor that is affecting the seventh nerve. Those MRIs, by the way, work best when they are gadolinium enhanced MRIs. The answer on the exam may actually give you that extra little detail. All right, vignette number 14. A 45-year-old man presents with a 2 cm FEAR mass in front of the left ear, which has been present for 4 months. The mass is deep to the skin and it is painless. The patient has normal function of the facial nerve. Any mass in front of the ear, behind the ear, around the angle of the mandible, any mass in this area should be diagnosed as a parotid tumor until proven otherwise. Now it's true you could have a lymph node in there, you could have a lipoma in there, but don't bet on that. Okay, so any mass in front of the ear, any mass around the angle of the jaw, any mass right behind here, that's a parotid tumor. Now what's the significance of that? The most common form of parotid tumor is a benign tumor called pleomorphic adenoma, which typically gives no pain and no paralysis of the facial nerve. So actually this vignette is a pleomorphic adenoma, because we're told that there is no pain and no paralysis of the facial nerve. But the pleomorphic adenoma, even though it is a benign tumor, it has potential for malignant transformation, and we want to remove them electively when we find them. But there is only one chance to do the proper elective removal of a pleomorphic adenoma of the parotid gland, and that's the first time we operate on that patient. Because in that virgin territory that hasn't been operated before, we can do either a superficial parotidectomy or a complete parotidectomy, the tumor is deep to the facial nerve, and do that operation sparing the facial nerve and cure the patient. But if we do something less than the formal superficial parotidectomy, for instance, if we do a nucleation of that tumor, it will grow back for sure. Recurrence is predictable after a nucleation of a pleomorphic adenoma. And then if at that time an expert then is called in to do the formal parotidectomy that should have been done in the first place, now it's far more difficult to preserve the integrity of the facial nerve, because now we're operating on tissue that has the scar of the previous operation. So don't pick any answer on this question when you do things to that mass. Now, you could always do the FNA. Remember, the FNA can be done virtually in any place, in any circumstances, with very few contraindications. In fact, the only contraindication that I can remember at the moment to doing even an FNA would be when we think a patient has hemangiomas in the liver. We don't like to put needles into a hemangioma. But you could put a needle for an FNA here, but no more. The patient who gets a little biopsy done under local anesthesia in the office. First of all, the person doing that may be unlucky and transect one of the branches of the facial nerve in the process. Now we have facial nerve paralysis already. Or you may end up with a salivary fistula. That's common when people mess with the parotid gland. Again, be sure that the answer you pick is this patient is referred to the proper expert who will do the formal superficial parotidectomy or the formal total parotidectomy, sparing the facial nerve. Figure number 15 gives you the other example of parotid tumors. A 65-year-old man presents with a 4 cm hard mass in front of the left ear, which has been present for 6 months. The mass is deep to the skin and it is fixed. He has constant pain in the area, and for the past 2 months he has had gradual progression of left facial nerve paralysis. He has rock-hard lymph nodes in the left neck. Now this is a cancer of the parotid gland. Because as I pointed out before, the benign tumors typically give no pain and no paralysis of the facial nerve. This is a cancer. Actually, this is one of 6 different kinds of cancer that we can have in the parotid gland, but it is malignant. And again, the management is the same as pointed out before, referral to the experts. The experts, in fact, will here do a total parotidectomy with sacrifice of the facial nerve, with the lymph node dissection in the neck, and then they will do a nerve graft, taking one of the sensory nerves that are nearby and using it as a graft. But again, this is easier to do the first time around, better the first time around than if somebody messes with it, cuts into it, and then forces the hand of the expert in terms of where to put the incision, how to do the resection, etc. We have a few vignettes here that I have labeled pediatric ENT, although they refer to only one particular issue. The issue, let me tell you first what it is. Anytime we see unilateral manifestations of ENT problems that typically should be bilateral, and they are happening in a little toddler, 2-year-old, we should think immediately of a foreign body. Figure number 16, a 2-year-old has unilateral earache. A 2-year-old has unilateral foul-smelling, purulent rhinorrhea. A 2-year-old has unilateral wheezing, and the lung on that side looks darker on x-rays, more air, than the other side. These little kids have a little toy truck or a peanut or something, either in the ear, up the nose, aspirated into the tracheobronchial tree. And so the correct management for any of these is the appropriate endoscopy, obviously under anesthesia. You cannot approach a 2-year-old with a bronchoscope and say, okay, lie quietly here, I'm going to put this thing down your throat so you can retrieve your little toy truck and you can play with it again. Incidentally, don't expect that foreign body would always show on x-rays. Many of the foreign bodies that are most commonly ingested, aspirated, stuck in the nose or in the ear by little kids are not radio-opaque. All right, let's move on to a few ENT emergencies and some miscellaneous things. A 45-year-old lady with a history of a recent tooth infection shows up with a huge, hot, red, tender, fluctuant mass occupying the left lower side of the face and upper neck, including the underside of the mouth. The mass pushes up the floor of the mouth on that side. She is febrile. Now, you have no trouble recognizing that this is an abscess. Red, hot, tender, etc. This abscess, though, has even a specific name. It's called Ludwig's angina, because it's an abscess of the floor of the mouth, and that abscess has an extra implication. It may interfere with the airway. So often the treatment of these isn't simply to do an incision and drainage, but it may also require a tracheostomy or intubation to secure an airway, and then the incision and the drainage. So think airway in addition to the standard thinking for an abscess when you're given this one. Opinion number 20. A 29-year-old lady calls your office at 10 a.m. with a history that she woke up that morning with one side of her face paralyzed. Well, we just touched upon this a few minutes ago, and we said this is a presentation for Bell's palsy, and Bell's palsy is benign. Or is this an emergency? Well, it is in a very relative way. Bell's palsy is indeed common, it's indeed benign, and it's self-correcting. There is, however, some feeling on the part of the ENT community. There are some medications that may help resolve this process a little quicker. Steroids have been used extensively for this. But more recently, antiviral medications have also been used. The thought being this may be, in fact, a viral infection of the seventh nerve. Well, you know that for antiviral medications to be effective, they have to be given as early as possible in the course of a disease. That's why when a healthcare worker becomes injured with a needle that has been in contact with HIV, positive fluids, that person has to get the antiviral medication immediately, within the first hour. So antiviral medications, if they are going to be used, have to be given immediately. And so the answer of this vignette, if a lady's on the phone saying this happened to me, the answer would be, ma'am, go to the drugstore around the corner. I'm going to phone in your prescription for antiviral medication. I want you to take the first tablet as soon as you can. All right, move on. Page number 21, a patient with multiple trauma from a car accident is being attended to in the emergency room. As multiple invasive things are done to him, he repeatedly grimaces with pain. The next day, it is noted that he has a facial nerve paralysis on one side. Trauma can indeed injure the facial nerve. But otorhinolaryngologists very quickly can distinguish the injury that needs correction from the one that doesn't. If a patient came into the ER unable to move one side of the face, then something has happened to that facial nerve as a consequence of the trauma, and some operative intervention is needed to rescue that nerve from wherever it is entrapped or injured, or perhaps they need to be reanastomoed, whatever. But when we have this presentation, when the patient came in, the patient already sustained the trauma, came in, the nerve was working. Everybody could see the face moving. The next morning it is not. That is swelling of the nerve, and it doesn't need anything done. It will get well again. Vignette number 22. Your office receives a phone call from Mrs. Rodriguez. You know this middle-aged lady very well because you have repeatedly treated her in the past for episodes of sinusitis. In fact, 6 days ago, you started her on decongestants and oral antibiotics for what you diagnosed as frontal and ethmoid sinusitis. Now she tells you over the phone that ever since she woke up this morning, she has been seeing double. Now, this new development has ominous significance. This lady began with an infection right here, near the orbit, near the brain. And now her inability to see the two clear images means that she's got paralysis on one of her eyes, and therefore she's seeing double. And this means either one of two things, both of which are emergencies. She has developed orbital cellulitis. From that infection, they are moving on to the orbit, or the infection has gone backwards into the cavernous sinus. And now she has infection of the cavernous sinus, where all those little nerves that eventually get to the eye travel through. And so this is an emergency in either case. CT scans will be needed to define where the infection is. Immediate intervention will be needed. Let's move to examples of epistaxis. A 10-year-old girl has epistaxis. Her mother says that she often picks her nose, and her mother is probably right. Bleeding from the nose in this age group is most commonly from the anterior part of the septum, and it is indeed from direct trauma, which means that this can be approached with local pressure, or with an anterior pack, or with epinephrine, soaked packs. But contrast that to the next one. An 18-year-old boy has epistaxis. The patient denies picking his nose. No source of anterior bleeding can be seen by physical examination. In this age group, the two leading causes of nosebleeds are either septal perforation because of cocaine abuse, or a posterior juvenile nasopharyngeal angiofibroma. The latter is a tumor that happens to young people, even younger than this vignette has. This vignette could have been 14 years old for the juvenile nasopharyngeal angiofibroma. And even though this is a benign tumor, it does bleed, and it typically bleeds posteriorly. But it also has a relentless growth where it destroys all the nearby structures, so they have to be removed surgically. Okay? So these are the two best diagnosis for epistaxis in this age group. But if we move to an older patient yet, then we have a different set of circumstances. Vignette number 25. A 72-year-old hypertensive male on aspirin for arthritis has a copious nosebleed. His blood pressure is 220 over 115 when seen in the ER. He says he began swallowing blood before it began to come out through the front of his nose. This is indeed the way the hypertensive bleeds typically are. So the nosebleed that is due to hypertension, as this one is, it's typically in the posterior part of the septum. And in fact, it can be life-threatening. So don't pick an answer here where you put local pressure, phenylephrine, little soaks or anterior packing, because it won't do any good. And in fact, the patient could go on and bleed to death. So this patient needs, at the very least, a posterior pack. And he may even need the ENT people to operate on him and ligate the offending vessels. All right, the last two vignettes have to do with patients that report being dizzy. They only touch upon one very simple, fundamental thought. A 57-year-old man seeks help for dizziness. On further questioning, he explains that he gets lightheaded and unsteady, but the room is not spinning around. And in contrast to that, vignette number 27, a 57-year-old man seeks help for dizziness. On further questioning, he explains that the room spins around him. Now, this is again one of those oversimplifications that I'm so fond of, that I've used so extensively in our review. But this is a good beginning point. When a patient says, I'm dizzy, my equilibrium is failing me, this is a pretty vague description. It may be a problem in the cerebral cortex or cerebellar cortex. It may be a problem inside the head, or it could be a problem in the inner ear. And one of the easiest ways to begin this differential diagnosis is to inquire about this detail that I mentioned here. So when a patient says on further questioning, no, the room is steady. I don't see the room moving, but I cannot remain stable. I stumble around in this room. The problem is the cerebellum, the problem is inside the head. When the patient says, I'm sitting or standing perfectly quiet, but the room is stumbling. The room is moving around me, it's spinning. It's like I'm inside a washing machine, which, by the way, is a very frightening feeling. The patient may, in fact, convey that fear that here I am standing or sitting, but the room is spinning around me. That is typically an inner ear problem. And so the workup in either of these two, one would go in the direction of looking at blood supply to the head, the other one in the direction of looking at what's happening in the inner ear. And that concludes our review of the ENT vignettes.